I am Woong Kang from Gachon University Kiel Hospital. So today my talk is the endovascular management of chronic aortic dissection. So aortic dissection is classified depending on the involving anatomy, so DBK type and Stanford system. Stanford system is the most popular. And also dissection is classified depending on the time of initial event, acute and chronic. And recently, the event occurred between 2 or 6 weeks is classified as subacute dissection. Type B dissection accounts for 30 or 40% of all dissection. So there are many complications occurred in type B dissection. About 30% of type B dissection are complicated in initial time. So at the time we required the intervention. So for chronic aortic dissection, the dilatation and aneurysmal change is the most common complication, like today's case. So treatment modality, we can classify the acute versus chronic and complicated or uncomplicated. For chronic uncomplicated dissection, we can compare the optimal medical treatment and endovascular treatment. So currently, the uncomplicated aortic dissection, the optimal medical treatment is the gold standard, but the long-term result is not so good. So mortality rate is 25% in 30 years. So we need another option. So recently, the endovascular therapy is suggested of alternative treatment to replace the medical treatment. Instead, the trial is a randomized comparison of strategy for uncomplicated chronic type B dissection. So all 140 patients enrolled, and 72 patients were allocated in the endovascular treatment, and 68 patients were allocated in the medical treatment. Primary endpoint was after 2 years all-cause mortality, and the secondary endpoint was aorta-related death, aortic dissection progression, and aortic remodeling. So as you can see here, the study results were negative. Cumulative survival rate, aorta-related mortality, and the combined endpoint of progression and the adverse event were similar between both groups. One of the goals of TEVAR in aortic dissection is aortic remodeling. So why aortic remodeling is important? So several data showed aortic remodeling is associated with good survival rate, and persistence of forced lumen perfusion is associated with disease progression. So instead trial, so in regarding the aortic remodeling, so aortic remodeling occurred in 91% in patient TEVAR group, and versus 19% of aortic remodeling occurred in the medical treatment. But there are just several limitations in instead trials. So this study showed there is no difference in mortality endpoint, but this study underpowered because only 40% of expected event occurred within 2 years. And there are many patients in medical group cross over to the TEVAR group. So STEnt APCIS study was conducted to see the long-term effect of TEVAR in uncomplicated aortic dissection. So after 2 years, all-cause mortality, aortic specific mortality, and the combined endpoint was lower in TEVAR group. This study suggests survival benefit from preemptive TEVAR in type B aortic dissection in addition to optimal medical treatment. So aortic remodeling of dissected aorta seems in concordance with long-term survival. So another study, there is another study showing the stent graft versus medical treatment of uncomplicated chronic aortic dissection. Total 300 patients enrolled for this patient. They compared TEVAR and medical treatment. So follow-up duration was 28 months, and the cumulative survival rate tended to be lower in TEVAR group compared to medical treatment group. And aorta-related mortality was lower in the TEVAR group compared to the medical treatment group. So in terms of aortic remodeling, so good aortic remodeling was showed in the TEVAR group. Current guideline and consensus for treatment of chronic type aortic dissection, if the complication there is no complications, medical management and imaging surveillance. And for subacute dissection, there is a similar. So if there is no complications, medical treatment and imaging surveillance is recommended. We need to review the previous data carefully. So STEnt trial was conducted to see the effect of TEVAR in chronic aortic dissection, but actually the most patient enrolled for this study was the initial event developed less than 6 weeks from endovascular therapy. So that means the most patient is not chronic, subacute dissection. So another study also showed the median time interval from onset to dissection to TEVAR was only 23 days. Also is a subacute dissection, not chronic dissection. So based on this data, there's some consensus preemptive TEVAR, if provided at very low risk, is increasingly being accepted for initial uncomplicated dissection. Anatomically suitable patient with considerable life expectancy more than 2 years should be offered preemptive TEVAR with the idea of preventing late complication. Next topic is the chronic complicated dissection. So we can compare the open repair and the TEVAR. But the direct comparing data, TEVAR and the open repair is very rare. So based on the pooled data of TEVAR and open repair for chronic complicated dissection, so in TEVAR group, the low early mortality, low early stroke, and the low early spinal cord ischemia, and the 5-year survival rate is similar in both group, and the freedom-free reintervention rate is higher in open repair group. So current guideline and the consensus treatment for chronic type B dissection, if the complication is developed, total aortic diameter more than 55 millimeter, and total aortic diameter years increase more than 4 millimeter, and the recurrent symptoms, we need intervention. So when you need intervention, we prefer the TEVAR rather than open repair. This is my conclusion. So most chronic type B dissection are managed medically and the complication develop. And there are some data showing the preemptive TEVAR, if provided a very low risk, is increasing being accepted for initial uncomplicated dissection. If there is recurrent symptoms, aneurysmal dilation and yearly increase of aortic diameter should be considered a sign of instability in the chronic phase and the indication of TEVAR. Or if the anatomy is unstable, we can perform the open repair. So early mortality in complicated chronic dissection, type B dissection is lower for TEVAR compared to with open repair. In uncomplicated chronic type B dissection, yearly clinical and imaging follow-up is recommended, irrespective of diameter and treatment applied. Thank you for your attention.